Okay, we're actually going to have a basic arterial blood gas review. So it's not going to get really deep. So I'm going to try to go over and make sure that you walk away with some really good information that'll be able to help you moving forward in your clinical practice. So the first thing we're going to do is we're going to talk about a little bit about learning objectives. I want to make sure that you can define exactly what an acid-base balance is, how to tell the difference between the regulations, the buffers, the respiratory system, and the renal system. Be able to identify or define what an acid disorder is, an alkalotic disorder. What are the causes of the acid-base disorders? And then here's the tricky part that everybody get caught up on, how to recognize if compensation has happened and exactly how does it work. So before we can get really big into talking about acid-base imbalances, we need to understand pH. And so I know students have a really hard time getting this. I'll just throw this out here. Not that it's really great need to know information, but pH actually stands for potential hydrogen, okay? And the pH is actually measuring the hydrogen ion concentration in the blood, okay? So that range could be anywhere between 0 and 14, of course, with 7 being neutral. The human body keeps a normal narrow range of 7.35 to 7.45. All right, so I want you to keep in memory, commit to memory, highlight on your PowerPoint or whatever. If the pH is lower than 7.35, the patient is said to be in acidosis, and there is an increased amount of hydrogen ions. So acidosis, increased hydrogen ions, a pH less than 7.35. If the pH is greater than 7.45, the patient is said to be in alkalosis, and there is a decrease in hydrogen ions. So you can't even move forward without getting this down. So I don't know if you want to write it on a yellow sticky and place it somewhere so that you can refer back to that. And remember that there's a very narrow range. Anything, like 6.8 or 7.8 above is kind of fatal and it doesn't work with life, okay? So that. Now you want to talk about what is acid-base balance. I'm not going to ever stop saying this because this is my favorite thing to say. The body is constantly fighting to maintain homeostasis. So in part of trying to maintain homeostasis, the balance is influenced by the production and the elimination of hydrogen ions. So your question to me is, how do we keep up with this production and elimination of hydrogen ions? So we have these chemical receptors, or what we'll call chemical buffers, that's running around in the body, and they respond immediately to changes in the blood pH. The second system that'll kick in is the respiratory system, and then the third system is the renal system. And you guys know how much I love talking about those kidneys. So chemical buffers, we're moving along. Chemical buffers, they are moving around. They are the fastest of the regulatory system. So they are immediate. They're changing now. As you are drinking your drink or not going to the bathroom or taking your Tums or whatever you're doing, they are immediately working all the time. They are receptors in your body. They provide immediate protection against the hydrogen ion concentration in the extracellular fluid. They are it's about 1 or 2 of them that run around in there. You have your hemoglobin and your plasma proteins. They act to resist the changes in the pH by binding hydrogen ions when the pH drop and releasing hydrogen ions when the pH rise. So remember, when the pH drop, we're in alkalosis, and when the pH rises, when the pH rises, we're in alkalosis, and when the pH drops, we're in acidosis. Our second system that kicks in to regulate the acid-base balance is going to be your respiratory system, i.e. your lungs. So this is our second way of kind of maintaining homeostasis. In in your normal breathing respirations, you are going to do your little gas exchange in the alveolar, and then you're going to blow off carbon dioxide, which is CO2. So the lungs' way of helping us maintain this homeostasis is in acidosis, the pH decreases and the respiratory rate increases in attempt to blow off the acid, which is the carbonic acid. And in alkalosis, the pH increases and the respiratory rate decreases in order to hold on because we're blowing off too much CO2. This system usually takes a couple of minutes to kick in. Our third system is the renal system. And the renal system is, of course, the most reliable, the most dependable, the big guns. And of course, it's slower to respond. So whereas the respiratory system is going to take a couple of minutes to kick in to do its compensation or to respond to an imbalance, the renal system usually takes hours, possibly days, for it to recognize what's going on in the body and to respond for it, where the 4-day mark is going to be the maximum of where it, when it does its job. The renal system acts by excreting excess hydrogen ions, and this is done in the proximal tubules. So it's going to excrete bicarb, hold on to bicarb, or excrete acid in the urine. That's its way of doing it. But like I said, it takes longer. It is less sensitive. So far we have basically covered what's the normal range of pH, what does it mean, and it's all based on hydrogen ions. An increase in hydrogen ions is going to be acidosis, and a decrease in hydrogen ions is going to be alkalosis. We understand that there are 3 systems that regulate this balance, that keeps this body in homeostasis, and those 3 systems are your chemical buffers, your respiratory system, and your renal system. And I'll go back and forth between saying renal and metabolic, and you'll see why in a minute. So on this slide, I want to talk about what components make up how we read or how we interpret our arterial blood gas. So the first thing I want to talk about is the blood pH, and we talked about it a little bit earlier. That range is 7.35 to 7.45, and I pretty much have how it is determined. Number 2, we're going to talk about PaCO2. So don't get all bent out about the PA. It's just partial arterial pressure. CO2 is carbon dioxide, okay? And remember, that's what the lungs blow off. I also would like for you to pay attention to, on the chart, it has hypocapnia and hypercapnia. Those words may be mentioned on a test. I don't know. I've never taken a test, but I use these words in class, and sometimes my students get all bent out of shape. They go with these readings. The patient is hypocapnia if they have a CO2 less than 35, and hypercapnia if they have a CO2 that's greater than 45. So don't get all thrown off by the words. Your CO2 is going to it's regulated by the lungs, and it indicates the amount of carbonic acid that is available to act as a buffer. It determines the condition of the respiratory system. And here's the thing, if it is less than 35, it's an indicative of alkalosis, and if it is greater than 45, it's indicative of acidosis. So I always write my blood gas levels in the exact same way. I always put the pH first, I always put the CO2 next, and I always put the bicarb next. So if you're one of those people that have a hard time remembering what these numbers are, remember your pH is 7.35 to 7.45, and your CO2 right up under it, you just drop off the 7. It's 35 to 45. I know, I always think of these cute little ways. So 35 to 45. The next one is going to be your PaO2. I don't want you to get your PaO2 confused with your SaO2, which we always go through when we put the little pulse oximeter on the hand. It is not the exact same thing. The PaO2 is the partial pressure of oxygenation in arterial blood. So it's allowed to be a little bit lower than what we expect from our SaO2. Okay, so it has a range of 80 to 100 instead of what we like, not greater than 95. So let's not get too bent out of shape. If that number is less than 80, our patient is said to be hypoxic or in hypoxemia. Now we have to talk about bicarbonate, okay? And I'm going to probably call it bicarb, but it is bicarbonate, so you guys know that. Or I may even refer to it as HCO3. Now, I know a lot of you are like, micro sucked and all this stuff, so we don't even have to worry about all of this or chemistry sucked. But this is the normal range, 22 to 26. You may see some values say 22 to 28. That's fine as well. Bicarbonate acid is a direct reflection of the renal system's ability to compensate for pH changes, okay? And a decrease is going to be acidosis, and increase is going to be alkalosis. So BE, which is base access, I have to be honest with you, at the beginner or novice nurse level, you do not have to know about base access, but because every now and then I like to throw out smart nurse stuff, I will throw that out there. It is an indication of the amount of bicarb available in the extracellular fluid. A value greater than 3 is metabolic alkalosis, and a value less than 2 indicates a metabolic acidosis. So it is definitely, it's a side note, throw it in there, and it has something to do more so with the metabolic component. So whenever you're getting ready to look at a blood gas, all of those systems are going to be there. All of these components. You're going to always have a pH. You have to have a CO2. You have to have a bicarb, and you will have a PaO2 and possibly a SaO2. Okay. So here we go, down to the nitty gritty. Here's the fun stuff, respiratory acidosis. So respiratory acidosis is the one you're always going to remember, okay? It's the patient that's not breathing. It has an increase of carbon dioxide or CO2, okay? So anytime you're looking, you see your increase in CO2 and your decrease in blood pH, you are immediately thinking respiratory acidosis, okay? It is caused by any condition that decreases the lungs' ability to blow off CO2. So let's think about some of that just really quick, just for a second. Let's get your attention. Hypoventilation. I don't want you to think I'm using really big words, even though I know you guys all have a great medical background. Those are our sedatives when we're giving our patients our benzos, or our pain meds, or the patient who is has COPD, anybody that's having a problem with breathing at an adequate rate, so they're holding on to the carbon dioxide, the CO2. That CO2 level is going to rise and cause them to be in respiratory acidosis. That also could be from somebody who has a chest injury who don't want to breathe because it hurts, okay? So don't get so caught up in that, and we'll talk a little bit more about things that cause that, and you know I like to talk about how the patient looks when they come in. So wouldn't be me if I didn't want to reach the visual learner. Here's our guy that's in respiratory acidosis, okay? So here are the signs and symptoms. You have your shallow respirations, difficulty breathing, and then over on the end here, we have causes of drug overdose, anesthesia, COPD, pneumonia, atelectasis. So he also has a cute little pair of lungs there that shows that his pH is decreased less than 7.35 and his CO2 is greater than 45. And this guy has the nerve to say, I can't breathe. So now we're going to talk a little bit about metabolic acidosis. So when we talk about the metabolic component, students get a little bit more confused about what's going on. So with the metabolic acidosis, it occurs when acid other than carbonic acid accumulates in the body, or when bicarb is lost from body fluid. So basically there's too much acid in the body and it's not a respiratory issue. That's what this all boils down to. One thing I want you to know is that this is rarely something that happens spontaneous. It is usually caused by some other kind of disease process. So you say, what other acid can accumulate in the body besides carbonic acid? You're absolutely right, lactic acid. So anytime we are trying to And guys, hold on. Let me stop for a second. You guys do know that acid, any kind of acid, is a byproduct of regular metabolism. So lactic acid is an example where the body is trying to do its metabolism, but it doesn't have enough oxygenation on board. So it's going to start building up lactic acid. So, of course, our prime example of that is going to be diabetic ketoacidosis. We love talking about it. Our patient who is on a diet, me, this girl, all the time, fever, hypoxia, ethanol intoxication, that's just drinks. So that's all the kind of stuff that'll get you to be in an increase of acidosis. So I wanted to give you a good understanding of what's going on with that. I want you to think, when you think of metabolic acidosis, I want you to think of any kind of kidney or pancreas issue that's going to lead to a bicarbonate deficit. Because that's where bicarb is made, just in case you know. That's one of those things you probably don't need to know, but little goofy stuff is always in my head. So here's our guy. He's in metabolic acidosis. He's coming in. He's complaining of a headache. He's hyperkalemic. Acidosis and hyperkalemic are friends. He has some muscle twitching, nausea and vomiting, diarrhea. Some of the causes: DKA, diabetic ketoacidosis, severe diarrhea. I have to be honest with you, metabolic acidosis, anytime a patient is having diarrhea out the ass is acidosis, renal failure, and shock. So you guys know how I love to do a little review before we move on. And that's what I'm going to do here on this slide. Causes of acidosis, whether it is a metabolic issue or a respiratory issue. And I have to be honest, I'm usually standing in front of a group of 30 people and I can ask questions around the class. And so to talk to my computer is a little bit different for me. So I don't get to ask you guys questions. But at the top here, we have a great set of lungs. And if I could ask you a question, I would ask you, what are some of the things that would cause respiratory acidosis? And you guys would be just shooting out COPD and bad nurse Betty gave too much pain meds and all that goofy stuff. And then as far as metabolic acidosis, you would tell me stuff like diabetic ketoacidosis, renal failure, severe diarrhea, and sepsis. That's acidosis in a nutshell, okay? So remember, your acidosis is going to be a pH less than 7.4. Okay, we're moving. We're doing good. And I think you guys are following me. I'm not really sure. Ira looks like he's following me. I don't know. Okay. Respiratory alkalosis. So in respiratory alkalosis, there is a decrease in CO2 and an increase in pH. That's the classic definition of respiratory alkalosis. So carbon dioxide is eliminated from the body faster than it can produce. So why would the body be getting rid of carbon dioxide so fast? The only way to get rid of carbon dioxide is to blow off carbon dioxide. So this would be the patient who is hyperventilating or the patient who is breathing fast. So deep, rapid respirations are usually the primary symptom that's associated with respiratory alkalosis. Let's think about some of the reasons why this patient would be breathing fast. Yes, PE, a fever, anemia, anything that's going to increase the respiratory rate, pain, anxiety, or the doctor who decided to put the vent settings for the rate to be too high. So that's the patient that's breathing too fast. They're breathing off the scared patient. So let's not get too beyond what we can do. So here's our great picture for our visual learner. This is our guy in respiratory alkalosis. He looks kind of goofy, doesn't he? I know. Anyway, so he's breathing really fast. His heart rate is elevated. He is hypokalemic. Remember we talked about hyper was going to go with acidosis and some of the causes for that. And I just throw this slide in so that our visual learner will have the opportunity to see some of the things that go on with that. This patient could be confused. They could come in dizzy. Those are some of the things. So now we have metabolic alkalosis. So metabolic alkalosis is indicated by a rise in the pH. So an increase in pH and an increase in bicarb. So remember I said on the previous slide that metabolic alkalosis was acidosis was a decrease in both. Here with metabolic alkalosis, there is an increase in pH and an increase in bicarb, and the result is usually from vomiting or some kind of excessive base intake. So now you're looking at my screen and you're saying, what the heck is an excessive base intake? So that's going to be your antacids, tum to tum. So you have that patient who is always taking their Tums, they're going to have an increase in base on board. So some of the things that are going to cause it, like I said, will be your NG suctioning, vomiting, or somebody taking Tums, or even us trying to treat diabetic ketoacidosis. We have you on a bicarb drip, and for some strange reason, we have you taking too much bicarb in. You may get some bicarb from your antibiotics or multiple blood transfusions. So those are some of the reasons that you would end up having too much base on board. On the flip side of that, guys, think about some of the reasons why you would have a decrease in acid on board, and that is going to be your vomiting. That's, vomiting up the gastric acid in your belly. We're taking out gastric acid because we're doing NG suctioning. And then your thiazide diuretics. And once again, here's our guy in metabolic alkalosis. He has, he's tachycardic. He is lethargic, confused, nausea, vomiting, diarrhea, muscle cramps, hypokalemic. He has a set of kidneys, decrease in acid, increase in base, and look, he's covering up his mouth so he won't vomit. This patient is hypotensive as well. So here's our little review. We're going to talk about just causes of alkalosis. Alkalosis, at the top we have your lungs, respiratory alkalosis, in the increase in pH and a decrease in CO2. This is the patient that is breathing too fast. They could be breathing too fast for quite a few reasons. Hypoxia, the body feels like it's not getting enough oxygen, so I have to breathe fast to get oxygen going. Fever, the body is going through a hypermetabolic stage. You have your pulmonary embolism, where the patient is just breathing faster because, once again, it doesn't think it's getting enough oxygen. Pain, there we go. High altitudes. That's very important. I keep seeing that concept tested. And then anxiety. Your alkalosis is going to be anytime the patient has a pH that is greater than 7.4. So when we get to the metabolic stage, remember, anytime we're taking out gastric juices, if we take out gastric juices, the patient is vomiting or we are NG suctioning. That's going to leave too much base in the body because we're taking out acid. Hydrochloric acid, remember? Okay, good. Anytime they're overusing their antacids, that's too much base on board. So I want you to remember those things. Now, this is where you guys get a little confused, and I don't know what happens in the world, but compensation. Compensation is not a really hard thing to understand. Compensation is the way that the body maintains homeostasis. We are always trying to maintain homeostasis. And in order to maintain homeostasis, we have to correct the pH. So, in order to do that, the body attempts to bring itself back into normal ranges, which is the pH of 7.35 to 7.45. The kidneys and the lungs both jump in to try to help out. They work together in this. The respiratory system, like I told you earlier, it's more sensitive. It jumps on almost immediately, couple of minutes, but it's limited and it is short-lived. The renal system is much more powerful, but it's less sensitive. And it's usually it takes a little bit longer to kick in. Like I said, several hours to days for it to do its thing. When you hear us say full compensation, we are referring to the fact that the pH is corrected, even if the CO2 and the HCO3 bicarb are still abnormal. The pH has gotten back into its normal range. Okay, I'm going to say that again because I do know that I speak fast. Full compensation is the pH is corrected, meaning that it is back into normal range. 7.35 to 7.45. Even if the CO2, carbon dioxide, and the HCO3 bicarb are still abnormal. As long as the pH has made it back into normal range, full compensation has occurred. So now we get goofy, and you know how we do it. We start talking about partial compensation. Partial compensation is the body's way of attempting to correct the pH. The pH is slightly out of the range, and the system still may be abnormal. So your pH may be 7.34, or your pH may be 7.47. It's almost back to normal range, but not quite. Okay, so that gets students sometimes. You know, people really have a hard time with trying to figure out compensation. One of the things I want you to know about compensation is that the opposite system of the imbalance compensates. The opposite system of the imbalance is the system that compensates. So let's do it. This is where you might want to pick up your pen or your highlighter or something like that. The good thing is that you guys get to listen to me over and over again. I did get some feedback to slow the hell down, so I'm trying to do that. So here we go. Respiratory acidosis is compensated by metabolic alkalosis. So basically what that means is when your body is in respiratory acidosis, your body is going to try to come into metabolic alkalosis to compensate, to get the pH back into normal range. So hear me out. If the respiration result in an increase in CO2 and a decrease in pH, increase in CO2, increase in carbon dioxide, and a decrease in pH. That's the classic definition of exactly respiratory acidosis. Then the kidneys will attempt to increase the pH by conserving or holding on to bicarb. So basically in respiratory acidosis, the kidneys say, wait a minute. She holding on to carbonic acid. There's a problem. Too much acid is on board. I'm going to hold on to mine. I'm not going to get rid of it because I need to basically neutralize this environment. It's too acidic. When a patient, I hope that makes sense. When a patient is in respiratory alkalosis, it is compensated by metabolic acidosis. Respiratory alkalosis is compensated by metabolic acidosis. Going back, the opposite system corrects the imbalance. Hear me out. If the patient is hyperventilating and results in a decrease in CO2, because if I'm breathing fast, I'm breathing off all of my CO2, which is going to cause a rise in the pH. That is your classic definition of respiratory alkalosis, a decrease in CO2 and an increase in pH. The kidneys will attempt to decrease the pH by eliminating, Now they're going to get rid of the bicarb. Because look, the lungs are breathing off too much bicarb. Too much acid. So there's no acid on board. So their job is going to be to eliminate the bicarb. Does that make sense? That's how the body is going to attempt to decrease the pH, by eliminating the bicarb. Because remember, the pH is high. Number 3, metabolic acidosis. Metabolic acidosis is compensated by the opposite system, respiratory alkalosis. Here's this example. If the metabolically produced acids consume bicarb and the pH falls. So we have a decrease in acids and a decrease in pH. The lungs will attempt to increase the pH by hyperventilating. Because remember, anytime we hyperventilate, we are blowing off CO2. So metabolic acidosis is going to be a decrease in pH and a decrease in bicarb. And our way of getting rid of this acid state, because remember, bicarb is basic, is to have the body hyperventilate to get rid of some of that. Metabolic alkalosis is compensated by respiratory acidosis. So metabolic alkalosis is compensated by respiratory acidosis. If bicarb accumulation increases and the pH increases, the lungs will attempt to decrease the pH by holding on to CO2. So the question is, how will the lungs attempt to decrease the pH by holding on to CO2? Exactly, by hypoventilating, okay? So basically what goes on is you're going to slow down on your breathing so you can conserve some of that CO2. The kidneys then reabsorb the hydrogen ions and eliminate the bicarb. And with this, you'll see the CO2 levels rising. This is very important for you to kind of get as you are moving through understanding compensation. I really want to make this video less than 45 minutes, but I do think that it is important to understand compensation. I'm going to run through it just one more time so that you kind of understand what's going on. The respiratory acidosis is compensated by metabolic alkalosis. If the respiratory dysfunction results in an increase in CO2 and a decrease in pH, the kidneys will attempt to increase the pH by holding on to bicarb. Respiratory alkalosis is compensated by metabolic acidosis. If you're breathing so fast that it ends up with a CO2 that is decreased and a pH that is rising or increasing, the kidneys will attempt to decrease the pH by eliminating bicarb or HCO3. Metabolic acidosis is compensated by respiratory alkalosis. If by some sign the acids are more than the base, So what ends up happening is you have a decrease in base and a decrease in pH, which is the definition of metabolic acidosis. The lungs will attempt to increase the pH by eliminating CO2. And the only way we get rid of CO2 is by exactly breathing it off. So ventilating. So they will hyperventilate. In metabolic alkalosis, it's compensated by respiratory acidosis. If you have an accumulation of bicarb and an increase in pH2, pH2, wow, and an increase in pH, you will have, the lumps will attempt to decrease the pH by conserving CO2 and by decreasing ventilation or hypoventilating. I'm thinking that I might add a chart in here so that will help out with getting a little bit more of understanding. But we definitely need to move on to exactly how to interpret an ABG. So when we are thinking about interpreting ABGs, we need to look at a couple of different things here. And the first step to interpreting an ABG is I look at the pH. I do want to put this in as a side note. If you're good at interpreting ABGs, have at it. If you have issues, try this out. I look at the pH. I determine if the pH is acidotic or alkalotic. The second thing I do is I look at the CO2. And we understand that CO2 is determined by the respiratory system. It is carbon dioxide, whether there is an increase in carbon dioxide or a decrease in carbon dioxide. An increase in carbon dioxide to me is acidosis. A decrease is going to be alkalosis. I determine if if the patient's respiratory status is in an alkalotic stage or an acidotic stage. And then I do the exact same thing for the HCO3 bicarb. I look to see if it's in a normal stage, acidotic stage, or alkalotic stage. If the bicarb is increased, it is alkalosis, but if it's decreased, it's acidosis. So basically, the first thing that I do is I find out if my pH is acidotic or alkalotic. Then I look to see if my CO2 is acidotic or alkalotic. And then I look and see if my bicarb or HCO3 is alkalotic and acidotic. And then I do my next thing, which is I match the CO2 or the HCO3 with the pH. Exactly. What do you mean, Miss Davis? Okay, so what do I mean by that? Is I look for the pH, I give it a last name. If the last name of the interpretation is going to be acidotic, I put that down. So, for example, if my pH is acidotic and my CO2 is acidotic, I realize that they go together. Acidotic and acidotic go together. So I realize that this is a respiratory issue and it is respiratory acidosis. So basically, when I look at the pH, I determine if it's acidotic or alkalotic. And then I find out who else is acidotic and alkalotic to go with it. So if my pH is acidosis, I'm looking for is the CO2 acidosis or the bicarb acidosis. That's why I say I give it a last name. The last name is going to be acidosis. I need to find out is the first name respiratory or metabolic. Okay, hope that kind of makes sense to you. The next step that I do is I look at, does the CO2 or the HCO3 go in opposite directions of the pH? I know, who cares? Exactly. If the CO2 or the HCO3 goes in opposite directions of the pH, there's compensation going on. For example, if the pH is acidotic and the CO2 is acidotic, and the HCO3 is alkalotic, so if the pH is acidosis, the CO2 is acidosis, and the bicarb is alkalosis, then we realize that there is compensation taking place there. And then the last step is I look at the O2 saturations, the PaO2 and the SaO2, and I find out how much, if any, there is hypoxemia going on there. So mild hypoxemia is going to be 50 to 60 for PaO2. PaO2 is what I'm talking about. Moderate hypoxemia is going to be 40 to 50, and severe hypoxemia is going to be less than 40. Like I said, remember your PaO2 is not the exact same thing as your SaO2. Your PaO2 can be from 80 to 100. So if we get a 50 to 60, we're going to say that's mild. They do have some hypoxemia. Hypoxemia is the decrease in oxygen in the blood, in arterial blood. So here is the thing that we definitely want to remember. You've probably heard it before, and I hope that you understand it. It's the Rome mnemonic. Respiratory opposite. That means that the pH is opposite of the CO2. So when pH is up, CO2 is down. When pH is down, CO2 is up. That's it. Respiratory is opposite. So it's a respiratory issue. Metabolic is equal, meaning when the pH is up, the bicarb is up. When the pH is down, the bicarb is down. I hope you understand it. When it was told to me in nursing school, I had no clue what that lady was talking about. She told me some Rome, respiratory opposite. She kept saying metabolic the same. So I guess I wasn't getting it wrong because same and equal, whatever. So I hope that this can help you out as you move forward in your practice. That pH is 7.22. Oh, here I go trying to get all fancy and use stuff. So you have your 7.22, and we recognize that anytime the pH is less than 7.35, that patient is said to be in acidosis. So my last name for this particular patient is going to be acidosis. Sit, instructor. All right. So, question. CO2 or HCO3 show acidosis? That's what I'm asking. Does the CO2 or the bicarb show acidosis? Well, my CO2 is 55 and my bicarb is 22. And just off the top of my head, I know that the bicarb is normal. But anyway, CO2 less than 35 is alkalosis, greater than 45 is acidosis. So my PaO2 or my CO2, my CO2 by carbon dioxide is 55. That means that it is greater than 45. Okay, guys? So our CO2 was 55, so it's greater than 45. So I'm going to say that that shows acidosis. The HCO3 was 22, so it is not less than 22. So the acidosis of greater than 45, 55, goes with the acidosis of the low pH of 7.22. So our patient is said to be in respiratory acidosis with